residencies. I went to from Arizona, Phoenix area, went to Arizona State, and then I went to OU for orthodontic residency. And I worked as an orthodontist for 6 to NYU for pediatric dental residency. Came here in 2019. Sweet Tooth is name of our offices. I work with Dr. Marquez. He and I are the ones that do the lip and tongue tie revisions. He's working right now, so he sent me here. So yeah, feel free. I mean, this is like an open forum, so if you have questions, just ask. Keep it pretty simple. But we do pediatric dentistry, we do orthodontics, obviously, and I've been doing the lip and tongue tie revisions since really dental school. So that was back in 2014. And then we did it a lot in orthodontic residency. We got into the infants and pediatric residency is where we work with the babies. But it was good having that background of really understanding things and going from adults and teenagers to babies, 2 and 3 day olds sometimes. So yeah, so it's maybe I've done it all the different ways. We'll talk a little bit about scissors, talk a little bit about like cold steel and sutures, and then using different lasers in there. So these are our doctors. Got pediatric dentists, a couple of orthodontists. These are our locations. We've got 6 right now, kind of spread out throughout Kansas City. We've got a few more coming. The surgery center is probably the one we're the most excited for, because right now we do all of our in-office, our sedation in office for pediatrics. And so we're excited to move everything to a surgery center. We're also for lip and tongue ties, which would be really helpful for our Medicaid population. It's just tough sometimes, as I think everyone knows, sometimes to be able to treat those patients. We do treat those patients. We don't treat anyone any different. We give pretty significant discount to be able to treat the patients for lip and tongue ties. We see patients that have Medicaid in Kansas and Missouri for pediatric dentistry, so we accept the insurance, but for lip and tongue ties, it runs through our orthodontic side of things. So, but we do give a really significant discount to try and help with that. So, moving on. So tongue ties. So I would imagine everyone knows. Yes.
I'm not.
Oh,
You're,
sure.
yes, if you don't mind using that just so we can make sure we all go.
Perfect. Okay. Great. Tongue ties. So lip and tongue ties. So what are they? It's normal. It's just a thicker remnant tissue that's left over. Sometimes it's really thick, sometimes it's thinner. I would say most of the time on these lip and tongue ties, it's pretty normal to see these, and it's pretty normal to have these. And I think most of the time it's not interfering with anything. And so most of the time I don't think it needs to be treated. I think by the time it gets to us, or say, I know we have quite a few different specialties in here. When you're seeing it interfere with certain things, I think there's an issue. And so it needs to be addressed. We really have probably the most acutely stressful, but fastest part of this in terms of helping, because we release that tissue and we'll go over stretches, kind of what we instruct on and everything like that, what to do. But it's not abnormal to see them. It's very common to see what looks like a lip or tongue tie having a little extra tissue in there. So how do you assess it? Really just lifting up the tongue, or asking patients to lift up the tongue if they're old enough and you're seeing it's restricted, or if you lift the tongue up on a baby, you can feel that tethered oral tissue, what we call TOTS, in there. And it's really if they're meeting a lot of the criteria, and mom's having a lot of the symptoms with nursing. And we have a handout over here for something that we give our patients, kind of a questionnaire when they come in. And if they're meeting that criteria, then we kind of go down the road of, okay, this may help. Let's kind of go down this road. But one thing I'm very passionate about is not over treating and not treating if we don't need to do it. Especially, we will offer same day, we book out an hour for it, so to discuss things and we have time to do that, but it's definitely something, if you're not comfortable, go home, think about it, talk to spouse, come back, that sort of thing. But that's how you're gonna kind of look and see if you think something's there, if you feel that that's restricted, or if they stick their tongue out and there's not good movement there. It does interfere with things, as we know, in nursing, swallowing, speaking, that tongue, having the normal development. On the dental side, the tongue sitting high in the palate, leading to a narrow palate, high vaulted palate. Hello, there's, okay. So we use the Kotlow classification. I know there's different ways that you can categorize this. For the tongue, it's basically type 1 through 3, and then there's posterior tie, type 4. Worse is type 1 going through, and then type 4, posterior can be tricky to diagnose and also kind of pull everything together that it is a posterior tie, because it can be kind of hidden and deep in there. So those ones can be a little tricky. The other ones are pretty obvious. For the lip, again, class 1 through 4. Further that goes down towards the incisive papilla, just 1 through 4. 4 is the most severe on there. So, and that's really something being able. A little bit better. Are you good? It's okay. It's okay. So that's class 4, going all the way down. Those ones are pretty obvious. We lift that lip up. The food can get stuck up there. As teeth come in, we've seen cavities, lots of cavities all across teeth sometimes, where it's just hard to get up there. It hurts when you're brushing the kids' teeth. I don't know if this is more annoying for you all. Until someone says something, just kidding. Some examples, they can vary in appearance. Some photos that we have, just kind of looking through. You've got some class 4s on top, class 1 there for the tongue over here, kind of the way they come through. So you do have to be careful of you have to know your anatomy when you get in there. There's sublingual gland, there's ducts that come through. You don't want to hit those, obviously, right here. Those sublingual ducts. Want to steer clear from those. Up here, not as much going on. There are sometimes superficial veins that you can hit, and so you have to be able to handle complications. I think maybe 2 or 3 times I've had that happen. It's not an emergency, it just takes about. Laser was right there. Embarrassing. And so what do you do if that happens? You apply pressure for 15 minutes, use a tea bag, wrap it in Kleenex, put pressure under the tannins and the tea will help coagulate. But it's all part of doing it. But 99.9% of the time, it's very straightforward, as expected. I always say, and most of the time, 95% of the time, anyone can do any of this. It's the 5% of the time that something's not working right, that you need someone that's specialized, and same thing for your field. It's most things are straightforward, but you want to be able to handle complications and handle things as they come. Anyway, so again, some other examples here, and really the most important thing for us is what are the symptoms saying? What is mom saying, and then what are the symptoms like for the child? Not just what it looks like, because again, not this severe, but most kiddos have a lip or a tongue tie. I think we're finally done. Okay. So symptoms and function are the most important thing that we look at. So in dental school, for us, and in other healthcare provider situations, you don't learn about this at all. It's something that is just not discussed. It's really once you get into residency, and I would say that most pediatric dental residencies don't teach this either. I was pretty fortunate where we had full-time oral surgeons, and we had one of our, we had someone in the community that did these in his office that was an attending. And so he was really big on pushing this and us doing it, which was awesome. And so there's a lot of myths that go along with this. Kind of read through that. Like posterior tie doesn't really cause anything. It does. Again, hard to diagnose, a little tougher to treat just because it's so deep. Scissors, pediatrician. I know in the hospital lots of times they'll come in and clip. My opinion, my empirical evidence, that doesn't really do anything, because you don't really have the precision to get it comes back, it grows back basically. ENTs do these as well, but they will not do it while the child's awake. They want general anesthesia. We do it, we love it. We love doing it while the kids are awake and like 2 and 3 years old and just screaming. We love it. It's okay. And that is something, a point of some that do this, and there are not many in Kansas City, but some that do it won't treat anyone over 1 year old. Again, we love treating the 2 and 3 year olds. It's our favorite. But we do it. Dr. Marquez is super, super great. He does it now. He does it more days than I do. I do it on Tuesdays. We do it out of our Olathe office, because that's where he uses a CO2 laser. That's where our laser is. He does it the other days. I'm there on Tuesdays. But really it goes to the symptoms and, are we having speech issues? Are we having nursing difficulties, airway issues? And leading to all of these other problems, breathing, transitioning, and then of course the dental problems that it can lead to with, needing expanders and not having what they need. So some of the symptoms, again, these are some of the things that we look at for the babies when they come in. Some things we talk about. It's on our questionnaire. What is the latch like? We take weight the day of, and then after usually see them back in 1 to 2 weeks, we take their weight again and see how the weight improves. What is sleeping like? I mean, everyone in here, y'all know if you've been a mom. I mean, I see it when they come in. It's like bloodshot eyes. They are tired, because they're pumping. They're having the feed. They are not sleeping. And they're like 4 days into having a new baby. And I'm just like, dang, it's crazy. And like, how are you sleeping? They're like, we're not. I'm like, I know, I can tell. It's hard. And they go through all of these, the reflux, the clicking, getting air, which just leads to air in the tummy, looking distended, digestion problems, a lot of, reflux, milk, coming down the side when they're eating. Frequency of eating, I mean, if it's every 15 minutes and they're tired and they go to sleep, everyone's worn out. And so what we do right away is we say, all right, let's, we talk about it, they want to do it after we have them feed right there. And this is probably the most rewarding thing that we do. Orthodontics takes like 2 years when you get this result. This is like boom. And don't quote me on it's every time, but it's like every time. It's awesome. Because when they come with these symptoms and they've been through, IBCLC, they've been through different therapy, different people, different specialties, and they finally get to us. Sometimes it's, their last hope. And when we release that tongue and that lip, it's like amazing. And it really is, I think, it's life-changing for mom, what she's going through right then, for the baby. It's really rewarding. So symptoms for mom, I'm sure be familiar with a lot of these. It's painful, bleeding, blistering cracks, nipples, incomplete mastitis, just things that are not fun to go through. Speech issues, getting a little bit older, things, having trouble saying certain letters, lisping, swearing words. Now, what the research shows is that if you are having these issues, it's 53% of the time doing a tongue release will improve speech. I tell them it's about half, a little over half. It's not a silver bullet. But I feel like most parents, moms, usually more often, most parents that are coming in are, they're checking boxes. They're trying to find a solution, especially as the child's getting older. They're not thriving for life, but speech things, stuff like that. They're checking boxes to try and improve the quality of life for both their baby and for them. And so the speech, it's about half the time that it's gonna help. The lip does not help as much as the tongue when you're at that age, or even early on, with speech. So, obviously this can be a controversial thing. I realize that. So that's why both my philosophy and I think it's a good idea to be conservative with it. So we don't treat, we want to be totally sure. And most of the time, when moms are coming in or parents are coming in, they're like prepared to do it that day. Either they've been consulting with y'all, they've done their research, they're coming in. I would say probably 90% of the time we do it the same day. Yes.
They, those are later now, and so even like with the research, are those pulled from speech therapists or are those dentists doing research?
I don't know. I
Yeah.
don't know.
And
It's
so
just what they've given us, yeah.
a lot of articulation development is up until 3 and 4 years old. And
Yes.
so I guess how do you guys know and what's that though? You can expect to see those until they are full.
Yeah, this probably isn't something that we're using in our consultation till they're probably 4 or 5 years old. So they're old enough, there probably should be meeting criteria. We're definitely not saying any of these things like an infant or 1 or 2. Yeah, but I would imagine it's not coming from dental, because we don't know anything about that. Don't know anything about any of the, y'all spook me up here, all that stuff, so I have myself. No teeth, so I know this, but I don't know the other stuff, so. But yeah, we're having a conversation, when mom's bringing it up and she's saying, I'm working with a speech pathologist, or, it's like, well, this is what I can say about the research, and whether this will help or not, it's like half the time. So, try not to promise too much, thank you. Yes.
If that's okay.
Oh, of course,
I
yes.
think that we say the word speech, and a lot of families just do like that encompasses talking. And there's a big difference between a child who's not talking and not trying to talk, and a child who maybe is trying to talk that's having some of these things. And so sometimes clarification with them with language and being able to use words. Sometimes parents are like, oh, he has speech issues, maybe this tongue pad will help, but really, they're just not expressing themselves yet verbally, and so.
Yeah, what does that really mean?
Yeah,
Yeah,
yeah, so sometimes there's like little nuances in that word speech that kind of,
right,
some parents like, in their hopes of, but really it wasn't the tongue tied, because we're really working on like more cognitive based expression.
yeah, and we're careful, you said that a lot more eloquent than I do, but we use that in our consultation, like, if a patient's coming in saying they're not speaking, we're not like doing a tongue tie for that, like, yeah, let's get this thing. Like, it's more encompassing, like, we're doing a whole exam, that's like a piece of the information. So, and again, we will refer, like, we're pretty quick to refer, and we're pretty quick to say, listen, we're like one adjunct piece to this, and we're probably in probably the sense of, like, we're probably the least important adjunct to this, but we gotta release it, but really all the therapy and everything, all the important stuff, the long-term relationship is here, not here, so. Yeah, so.
And I like that last one about trying to relate the.
Oh, yeah, I like that one too.
Good, good.
So. Again, symptom based, but feeding issues, you can read through this, but if they're having these things, and it's not like, hey, I think I spit their food out last night, I think there's a tongue tie. That wouldn't be the criteria, but it's putting all these pieces together for us, kind of looking at all of them, encompassing really just kind of leading down that road of, okay, this makes sense. And again, most of these patients that come in have already, a lot of them have already seen a lot of you out there, and they're kind of being funneled in to this. Yes,
Okay, so dietitian.
yes.
So is the reflux a result of swallowing the air because of the time? Then how does constipation go in?
They're gonna be
Oh.
unconscious. All the specialties, but it is related, I know it's related,
Okay,
to digestion and the metabolism.
okay.
So having air, get the air in the
The
tummy.
reflux makes sense.
Mhm.
Trying to be together.
Well, I am too, thank you. Let's get to the end. No, this is, I mean, this is good, like, conversation, so, like specialists here. Okay. Okay, yeah, it's might be the last time.
Really, I wanna know.
Okay.
How would it How would the parent get information and then they relate it to us? And we know there's like breakdowns in like information and communication, and we know that it's just because it's how, not, yes. So knowing some of the things that you guys say is helping us, so that we like reinforce it when we're.
Good. Good. Well, thanks.
Okay.
Okay, next slide. Sleep issues, okay, I'm a little more comfortable with this one. Here, well, okay.
Very more speak.
So, like, you guys heard all that research in the last, kind of like 5, 8 years now, all the research coming out on ADD and ADHD and lack of sleep and how it leads to that. Not, you know, that when the tongue can't be released, it stays down, which means it stays back, and it doesn't go up, which creates that narrow palate. And now you need an expander when you're 8 years old. So it's all related, and if you're not getting oxygen, right, now not getting oxygen, your body is wanting oxygen. And so snoring, trying to get that oxygen in, not sleeping well, bedwetting, tooth grinding, all these, your body's fighting to get oxygen. And so it's all, I mean, you know, body, it's all related. And so, constipation. It's back. That's it, so, oxygen.
The sleeping sort.
I don't think it necessarily gets worse over time. I know a lot of the teeth grinding, and because as you grow and develop, you'll have vertical growth as well. And with your teeth, they erupt more. So a lot of times, some of these last ones, the tooth grinding, the mouth breathing, that'll a lot of times get better because you're having vertical growth with your teeth, and there's a neurological connection, brain and muscle mastication, that when the occlusion changes, then your bite changes. So you're not grinding. Most kids, for example, will grow out like. I have probably once a week parents concerned about how much their 4-year-old is grinding. They can hear it from the other room. And they go in and try to wake them up, and maybe some of the experience that I know I did with my daughter when she was little too. And most of the time you grow out of it. Not always. I mean, probably know some adults that have an occlusal splint they sleep with because they grind. Most of the time you grow out of it. And so I haven't seen a correlation of it getting worse over time. It probably gets a little better over time. Just as everything is growing vertically and everything is expanding naturally with growth, you get a little more room. But then you're looking at like adenoids, tonsils, how wide is the palate? And this palatal expanders help a ton in this too. I've had a lot of patients come in. I've had some referred just for this, for sleep, to get a wider expander. There's research to support that. That does help. Where less bedwetting, ADHD has been decreased because you're increasing the circumference of the airway. So with just an expander. So. All right, other correlated issues, there's the ADHD, sensory issues, teeth decay, I would maybe once a month. Let's see, on these front 4 baby teeth with the 2 or 3-year-old that has a lip tie, pretty severe lip tie. And mom can't rush up there because it hurts so bad, so she doesn't because it's uncomfortable for the child. And there's decay, just kind of rotted out, looks pretty much just like this all across there. And there's plaque and food up there, most if they've ever brushed up there. You know, because that tie comes so far down that it's super uncomfortable, and so they just don't do it. They don't know any better. They just don't do it. And then, you know, and then to boot, going to bed with milk or going to bed with whatever, bottle. But it can lead to a lot of these things. Again, oxygen is a big one, and so it leads to a lot of these things trying to get oxygen. Yeah, head and neck. I actually did, I should have taken some pictures. I think we do have pictures, I should have loaded them. For Dr. Marquez, like 4 months ago, he had me do his tongue tie revision. And he swears, he's like, I don't have any more shoulder pain, like everything's been released, like I feel so much less stress. I'm like, all right, that's awesome. But it worked. You know, and it's like, I mean, I do this, but I'm open to all this stuff. I'm not like on one side or the other. I know it's controversial. I just, hey, if you like it, I like it. It's like, I'm glad that works for you, and that's good. But he swears by it. So, and there's a lot of research to support it, and there's a lot of haters, and it's, we go by symptoms. We go by symptoms. So, this is the laser we use. It's a light scalpel CO2 laser. It is like Star Wars. It's awesome. You can be like this far away, and you're going to ablate the tissue. I've done it every way you can do it. I've done it with scissors, where you place sutures. You go in with scissors to do the entire procedure, then you put sutures. That's not going to work on like a 5-day-old, right? The one at the bottom, this is called a diode laser. It's basically, this is glass. This is a ream, and it's glass that comes out. And this is probably 90% of dentists use this. And if your dentist is using this on your lip or tongue tie run, that's not what you want. It's like searing a steak. It's putting hot glass on tissue. And that's what they use. And that's very common in dentistry. So we don't use that. We use a CO2 laser for the reasons that are listed here. It's so much better, so much easier. You have coagulation of blood vessels right when you're doing it. It actually seals off the nerve endings as you're doing it. Not saying it doesn't hurt the babies, because we don't know them until 10 months. So I've had patients come in that are like 7, 8 months old, babies. Well, they come with their parents, obviously. And it's like, let's delay this a few months, because then we can know. Because at 7 months, the nerve endings are not fully developed early on. And so once you get close to 10 months, it's like, why not wait a little bit longer, then we can numb, and then it's not as hard of a procedure for the baby. But it's very precise. You can take your time. You can really get really good vision, what you want to see. The CO2 laser actually will kill bacteria, virus, and the mouth is really an area that's really clean, relatively speaking. Doing surgery in the mouth, tons of blood flow. Like, we're really fortunate as pediatric dentists that we work in the mouth, because there's so much blood flow. And so I've never seen an infection happen. Done thousands of these, never had any problems. We do not do general anesthesia, we don't do sedation. We could, we just don't, because it's such a fast procedure. At most, it takes a few minutes. If the baby's really upset, really strong, and they're closing their mouth a lot, it can take a little longer to get under the tongue. That's where your anatomy is that you want to be careful of down there. But healing is much more comfortable with this, because you aren't actually taking anything hot to the tissue, and the effectiveness is much better than scissors, because you're able to get into the tissue that you want to and really be finite about it. Yes.
What was the name of the machine you said do not do?
Diode laser.
Okay. Thank you.
DIODE. Just CO2 laser is really the standard. So, yeah, we vaporize the tissue. It is what it sounds like. It's blowing up the tissue at a microscopic level. The water is exploding in the tissue. So during the procedure, just an example, we wrap the babies with loose glasses. Everyone in the room has glasses. I like it when the parents are not in the room, it's less stressful. But if they want to be in the room, that's okay. I think most prefer not to be in the room. So, but yeah, we do all the stuff there, before and after, that's like right after. This is good, this is enough. That's good, that's enough. I've seen some get really deep and really transverse along here. It's not necessary. As long as we're doing exercises, kind of what to expect for the days, day 1, 2 through day 10. You will see it, and I tell them it's gonna look like it's infected. It turns yellowy whitish, it's like a scab, but it's wet. So if you think of that, it's kind of yellowy whitish. Infection would be much different. It would be super red all along. It would be inflamed. It would be, you'd have this huge Kardashian lip. It would be, it would not look right. And with our office phones, patients can text photos to our office, just our normal office number, and it comes through as a photo. So some of these patients who live like further away, an hour, we have patients come from like 3 hours away. So we're like in the Amish communities, like we're in with them. So like they get their driver and they come up and they don't come back. But they don't send photos, but they don't come back usually for like a follow-up. But we tell them what to expect and so that they know kind of it's gonna look infected, it's not, here's what to expect if it is, here's if you need to come back and it's an emergency. But we always do a follow-up. Coconut oil sometimes gets soothed. We put coconut oil on there for a few days, helps it feel better. Tylenol, ibuprofen, as appropriate as needed. Exercises, this is the most important thing we do. If you're not gonna do the exercise, you might as well not even do it. My favorite is like teenagers, when we do this and we come back and I'm like, God, it looks exactly the same. What happened? And they're like, oh, she said she was doing the exercise herself. I'm like, okay, well, do you trust them to do anything themselves? Like, I guarantee they're not in here like pulling the lip up and pulling the tongue, but we do 2 to 3 weeks of exercise. We see them back usually within a week or two. I like to do 2 weeks. Dr. Marquez does 1 week typically, but in 2 weeks, that's when we decide, okay, we need to do another week or we're good, everything looks fine. But this is primary intention, healing and secondary. This is secondary. We don't want it to be like a suture, right? You want it to stay open. And so that's why we do the exercise, because if you do the procedure, you leave it alone, it's just gonna heal right back, both the tongue and the lip. So we want it to stay open, and it is gonna be uncomfortable for 2 to 3 weeks, 4 to 6 hours a day. You start the same day. If it's a morning appointment, try and get like 4 in that day. If it's an afternoon appointment, a few more. No need to wake up the kiddos in the middle of the night. Just do it before they go to bed, do it right when they wake up. It's easiest, depending on the age, but it's easiest if you lay the head in your lap, like on the couch, and for the lip. And the tongue, just to lift the lip and then lift the tongue from this direction. If you want to use the headlight, flashlight, but you lift the lip up and you just crank on that thing. You pull it up. You're not gonna, I was telling you are not gonna cause any kind of trauma to the tissue. You're not gonna tear the tissue. You're not gonna rip anything. But you may see some bleeding. If you see bleeding, that's not a terrible thing. That means it started to heal. And so you just released that. It will still continue to heal, but you want to keep that open because you're having secondary intention healing. It's like if you fell on the street or the sidewalk, you want it to fill in. as it heals, and you'll see a diamond. It's kind of very typical, stereotypical under the tongue, and then on the lip, and it'll be white and yellow look, have that kind of pussy infection looking, but it's not. That's just the scab, and it's wet, and it will just slowly come together. And once it's all the way together and it's pink, then you're done. It stretches, and it is great. And so most patients come back and it looks really good. The tongue is the hard one. That's the hard one. You can't see in there very good on these little mouths. And moms, a lot of times, are uncomfortable. There's no moms doing exercises, dads aren't doing them. It's always the moms. And, you get Q-tips. If you can get a Q-tip in there, 2 Q-tips, and just stretch in there, because it's just hard to see. It's so dark, it's so little, and they feel like they're hurting their baby. So it's all just a combination. It can be a little tough, but usually they do pretty good. Let's just talk about reattachment. It's natural, it wants to reattach, it wants to have the primary healing. So you're fighting the natural inclination for the body to heal itself. So you really gotta do those exercises. And you pull on that lip, you pull on that tongue, you just wanna keep it open. So yes, it's really a collaborative effort. Like I said, where we come in to help, it's pretty fast, and we provide a little bit of information compared to what you all provide, and it's a fast appointment in and out. The real long-term person that's helping is not us. We're there to just do the release, provide information. We're kind of an in-between of, the start and the beginning. A lot of, there are definitely times where we won't treat because we need them to get to somebody first. Chiropractor, you see sometimes these babies come in, they're just curled up like this, and they're just super tight. So we want them to go see a chiropractor who can do body work, and the research does support that that's the most effective way and most efficient way if we do that before we actually do the procedure. Then we want to get them over to where they need to go first, if it's needed. So I think that's pretty much it. Yeah, it's just some of our team and stuff like that. So any questions that I can answer related to this specific? Yes.
Just like really touching my first. Or why are you doing that?
That would probably be more related to body work, and if they're still, it could go months where, I've seen 10 and 12 months old, well, a year old, just coiled up still, and like has been, still hasn't eaten well, like, striving for life still, and it's like, well, that's, the theory is this, and I'm sure like everything's connected. All this fashion and tissue is all connected, and it can be released, and again, it's like, okay, let's see, how this goes, but that's kind of where that's coming from. So yes.
So that release in the mouth is gonna help release all of it through the body?
That's the theory. Yeah. Dr. Marquez would say yes. I am open to that theory. I think it's more symptoms. I think if that's how you're feeling and we do a release and you feel like is a placebo, is it real? It's real for you. And I'm not gonna get up here and get on one side of the fence or the other. I'm just I see myself as like an intermediary, and how can I help the real Superman here, I do the release. So that's what I mainly have. Was there a question here first? Yes.
Like if I'm going to see a different pediatric dentist who doesn't do this, can I come to you just for
Yeah.
the surgery, or do you only work with your?
Yeah, for sure. And then we'll have you stay with us. No, yeah, we get that all the time because there's like no one else does this. Yeah, so yeah, we have a lot of family dentists, we have pediatric dentists that we'll refer over, send them back, yeah. Yes, and alcohol, yes.
So we have a lot, of medically complex kids who might not be like eating orally, maybe like soup bed or something like that. One question I have for you, not on the tongue tie realm, but on the like dental care realm, is, there's some mixed recommendations that I've read about oral care, especially for kids who are like NPO or not eating my mouth. What do you recommend? And then is that tied as far as like oral care with the parent? Is that ever a consideration?
Says, where do cavities come from? Do we know where cavities come from? Now you're mine, now you're.
Sugar.
Okay, so Streptococcus mutans, the only bacteria that causes cavities. Where does it come from? It comes from mom or dad, but it's vertical transmission. So it comes from kissing your baby, touching the food, make sure it's not hot enough, and then you give it to your baby. If you take a drink, and then your baby takes a drink. But if you give even a kiss, salivary, that's where the bacteria comes from. So can kids who've never eaten and they're on a feeding tube, can they get cavities? Yes. That's how they would get it. You're not born with cavities, it's vertically transmitted from parents.
So then. Doing oral swabs to clean and then say some will say just use water, a little bit of toothpaste, especially for those kids at birth of aspiration. What are we recommending right now?
So about fluoride. Again, us Western medicine trained, fluoride's the thing, right? I get, like, my cousin is one of like the biggest homeopathic remedy people in the country. She sends me stuff all the time. She's like, yeah, so, and I'm cool with both, like, I'm on the fence, like, if it works, like, we don't, like, my family, like, personally, like, my wife, our kids, like, we try never to use antibiotics. I haven't used antibiotics since, like, I don't know, I was a teenager, like, 20 years. And so we try not to use antibiotics, ever. So, fluoride, it is proven that fluoride kills Streptococcus mutans. That's bacteria. Is it a halogen? Yes. On the periodic table? Yes. Are there other things? Yes. So one thing you could do is use like an Act mouthwash, which has fluoride, or there's Listerine. Some of the Listerines have fluoride as well. All of the Act mouthwashes have it. Dip it, and then brush. Just so there's something on there. Xylitol, you've heard of xylitol, something like that. Fluoride's still standard of care in dentistry. So I know it's, again, a controversial thing, but, I don't know if that helps, but for dipping it, sometimes for different situations, that makes sense to just use the mouthwash so that you've got some fluoride on there, it's not gonna foam up. There's also aphthous ulcers like canker sores, this is just a side note. If you know anyone that gets a lot of those, if you remove the ingredients from toothpaste that causes it to bubble up, then that really reduces the frequency of getting aphthous ulcers. So you could try something like that too. It's weird, if you've ever done it, it's weird to brush, it's like brushing with water, because there's no bubbles at all. But there are some toothpaste like that and without it, so, there are a few more in the back. And then- Yes, okay, yes, yeah,
Back to some guys. Sorry.
you're good, yeah.
So when you release it and the family comes back and it has healed and now there's a tie again, are you releasing it again? Or what are the risks of multiple releases of the same thing?
Just in the first time, I mean, there is scar tissue there, especially on the tongue, so that you have to work through, so it's a little tougher. But no more risk than the first time. It's just, do the parents want to go through that again? Do they want to pay for it again? To have called a revision, to do it again. But I don't think there's any increased risk in terms of the procedure. It's just, my question is, well, are we gonna have a different outcome, or are we just gonna put the kid through this again and you have to pay again for it? Because I don't wanna do that if it's it's not gonna be a different outcome, we should do it. So, yeah, yes.
What's the prevalence of reattachment that you see at Hollow?
The tongue is the most common. I'd say probably, if I had to like take a guess, 10 to 15%.
Is that 1 week post or do you do?
I do 2 week. So probably the same for Dr. Marquez. It's really just because I really emphasize, gotta get in there, use some cottons and, use Q-tips, whatever you gotta do, you gotta lift that tongue or it's gonna reconnect. And that's just the toughest part. And the biggest reason is like, I felt like I was hurting him. I felt like I was hurting her. She was crying. I'm like, I know. And so I'll get in there and I'll stretch. And a lot of times I see it bleed. So I'll do like a proper stretch. And we show them stretches before. I'll review it after if they want to review it again. We give them a handout with written instructions. They can call anytime. We take call after hours, anytime. So, but yeah, the tongue, just sometimes they just aren't, I don't want to say they're not able to, they just they don't do it like they should. So, yeah, yes.
Is a release ever contraindicated?
Well, I think my definition in this, would be contraindicated if they don't need it. Like they're not meeting the symptoms, just because they have some kind of restriction. The reason for it changes, let's talk about, you're not meeting these symptoms. So do we need to do it now? Or do we kick the can down the road? To where, a lot of times there's a lip tie on like a 3-year-old, but it's not interfering with brushing. I really don't want to do it on a 3-year-old because we got to strap them down most of the time. You got to numb them, got to put them through that, costs money. It's like they're thriving for life. They are meeting all of their metrics, all of the milestones. Let's just kick it down the road. At a certain point, we probably will need to do it because there already is a diastema or there will be a gap between the teeth. And so then we fix it with orthodontics later, where once we bring the teeth together, now we remove that tissue and the tissue regenerates and regrows with the teeth in the new position. And when you're taking it all the way down to the bone, like you're taking it all the way to the facial portion of the maxillary bone. You're getting rid of all that tissue. So I guess in my mind, the contraindication is if we don't need to do it now, can we do it later? Is there a need to do it? So I don't think doing it you're not going to hurt the patient long-term or do damage to the patient, but it's like, why put them through that and why have the parents pay for that when you can do it later and it'll be better timed in life for the patient? Does that answer your question? Oh. Yes.
Not tie related,
Okay.
but I was just wondering, I see a lot of like cold teethers versus like frozen teethers, and I didn't know what the impact of those would be on gums. Like, is frozen not good for your gums as babies rather than like when they don't have teeth?
Cold teethers and frozen, I've never heard that term. Is that just like as they're teething in using something frozen or using something cold? Doesn't make a difference, as far as I know, I've never heard that term.
Oh, I don't.
Thank you.
Never mind.
No, that's fine. Just as they're teething, you give them something cold. No, I will tell them use something cold.
Okay.
Whether you pull it out of the freezer or you pull it out of the fridge, I don't think it makes a difference. Yeah, yes.
The cost involved, as far as insurance, or, so like if you have dental insurance, is it covered under that?
I'll only talk about this in the consultation. I'm happy to have the consultation. So this is where it gets a little like, I don't want to say dicey, so pediatric dentistry is different than orthodontics. The way that you bill, how much coverage you have, the way that it's covered. For example, pediatric dentistry, it resets every year, just like medical. But it's usually not as good as medical, but it's different. but it's the same, but it's different. So it usually will cover, I'll do, in Delta Dental, if you've heard of that, that's the big, they own the market share, like 70% of the market, people have Delta Dental for, insurance. So it's usually like a $1,500 of coverage. Well, depending on what's covered, the lip and tongue ties will be covered, but it depends if it falls into minor or major, and different, there's like 1,000 Delta Dental plans, your employer, every employer has a different plan based on what they want to cover. So for orthodontics, for pediatric dentistry, we take everything, pretty much everything, all the Medicaids, all the private insurances, pretty much everything. For orthodontics, we only take Delta Dental. That's because the business decision now, okay? Let's step out of that. Actually, they will send the checks to the patient's house if we're not in network. So we retired not getting checks. People say they never got them. So we're in network with Delta Dental and ortho. So, but it's still broken down where it only covers a percentage. And in fact, here's the funny thing, the Delta Dental rep upset with me because I wasn't taking it. And the patients pay more out of pocket with us being in network with Delta Dental than they would if we weren't. And this is what I explained to her, and she didn't care. She just said, you know, this is what we want. We can't do it for pedo and not ortho, which we can, but it was not worth me getting on their target list. We just did it. But they do pay more because we're in network with them.
And one other
Yes.
question, asking for a friend, is there an age limit since you're pediatric?
No, but, no, orthodontics, so for pediatric dentistry.
Yeah, well, I know, I meant for the
For tongue tie.
tongue and lip,
No.
is there?
I've done an 76-year-old and I've done a 2-day-old for lip and tongue ties. Same for orthodontics. Now, pediatric dentistry, once they're out of high school, we usually kick them out. Yeah, a lot of times the parents still like, because they can bring all the kids, even if they have like an older child. They like to know to bring them all to one place, but yeah. It's
Do you typically always do the lip if you're doing the tongue, or is it kind of based on the severity more so?
based on severity. I would say that probably 80% of the time they need both. And there's indication for both visually and just with symptoms. But if it's just it's usually on the older kids, like speech, like the older kids. Yes, you are. Don't come for me. So, yes. Hey, Uber here. Usually the older kids, the concern is the tongue. So mom's coming in, and so the conversation is about speech, so then I'm talking more about the tongue when they're older. We're talking about the tongue more, so we will usually focus on the tongue. We'll look at the lip, and if there is a lip tie, say if you want to get them both, here's what it is. We can totally, if they need it, it's like kicking it down the road. We already are gonna do the tongue. If you want to get them both, that's fine, since we're doing one. If not, we'll just do one. And I don't know, maybe 75% of the time only, they'll just do one, but then I've had them come back later to do the lip, and like, I should have just done it. Oh, that's fine, I'm glad you had time to think about it. And then sometimes they don't, sometimes they just do the tongue. So, yes, let me go ahead.
I mean, I think we maybe feel a little bit like hesitant is because it doesn't always, I don't think you guys are often in particular, but in the like talk, like that collaboration, like we obviously are working with those patients and kind of have some input, and just I think that piece sometimes gets missed where maybe we're not talking. I think about some of my kiddos that I work with, especially neurological, with that low muscle tone. I actually just had a little one come to mom last week who had all the revisions, mom's an LC, so she was all about it. Like he has a muscular dystrophy diagnosis, and now she kind of regrets it because of that tongue and that placement and that obstruction airway. Sorry, I get nervous. Alright, so I guess I'll
Here, it's a
think
lot.
about. I know.
Up here.
It's great hearing from your side of things, and I think
if there was more collaboration, like, hey, maybe this would be, that we wait a little bit longer, or
Yeah.
hey, maybe we need to try more things to work on that function.
Right. It really is, the lip and tongue ties is a complete opposite of orthodontics, and orthodontics, like, I'm in control. Like, you're not doing anything, you're not taking teeth out, you're not doing an implant, you're not doing crowns until I come up with an ortho plan to move teeth or separate, to create space. Like, I control everything. This is totally opposite. It's like, you just, which I kind of hate in a way, because they come in, they come out, and so, but it's really like, for me, it's like, who all are we working with? Who's the different specialists that we have involved in this for this child, and how do I help? Yeah, so, yeah. Right here, sir. No. It's,
And doing the buckle ties, is
we look at that at the same time. I didn't time about buckle ties, but we look at that at the same time.
that how frequent are you releasing those? And
50% of the time that we do the maxillary frenum, probably 50% of the time we do the buckle ties.
what's
Same time.
what the release for the buckle ties, what does that help with?
Same thing. When you're feeding, having the motion and not being restricted. And you can, when you pull, you can see that sometimes it comes all the way down over that arch on these babies. It just, all that restriction. Yeah, being able to get a good latch. It's the main thing. I would say like that's the majority of, we see lots of babies. And then there's kind of a break. There's kind of a break between the babies and then maybe like 2 or 3 years old. And then we're trying to push it into, if again, it's just not meeting those symptoms and we can push it till they're older. Like 3 to 7, well, really 2 to 7 is like really difficult. You can't negotiate with these kids. You can't they don't know why you're giving them a shot, why you're holding them down. And we use papoose, it's, so that's why we have sedation. So.
With the infants, the younger
Mhm.
ones, do you feel like the younger the better if they're having symptoms from the start?
I think younger the better for the baby and the mom. If it can be diagnosed, if mom can figure out how to find us, or if working with all of you, like trying to figure it out. Yeah, I think it just makes things easier in a day-to-day like living condition and confidence and just knowing that my baby's good. And again, a lot of times, like I mentioned, they're checking a box. They're trying to figure things out, and I'm just a box they're checking. So that's why I was like, well, I can't say this is going to work. I've seen it. I see it all the time. And I'm pretty confident, but if it doesn't work, really, most of this has to do with you doing the exercises. Because again, we have them feed right there, right in the same room. That's why we book an hour, so we've got plenty of time. And just the results are awesome. Yeah, right away. So here and then here.
Is there ever justification for medical insurance to cover the procedure?
This is a good question. We've thought about that. I think in the surgery center, it'll be a lot easier. That's one of the reasons we're excited about the surgery center, because we can do Medicaid without having to charge them anything, because there's different billing things with surgery centers, so they can come in, not have to pay anything out of pocket. I think the acceptance will be much higher. And then there are medical things that you can do. I don't have a medical license, and our software doesn't do medical coding. I don't think so.
Just
Yeah, we
curious,
looked at it.
because if we're talking about, how complex feeding can be,
Yeah,
the nutrition piece, all of
Mhm.
that.
and things will get easier in a year for this. I think it'll be a lot easier for patients to be able to do it, especially for just that lower income population. So somewhere, yes.
The latest stuff, we give you those. Parents through that. You guys in the evening, some oral versions, essentially have been looking at that.
Yeah, there was, I think I skipped on the slide, it was on there, but no, we haven't, but again, we only see them back like 2 or 3 weeks later. Most of the time they're, they either become pediatric dental patients or they already are, because once that kid, I think there was a question on, when to see the pediatric dentist. What's recommended is when the first tooth comes in.
Oh.
that can be pretty early, frankly, probably too early. We're just gonna look at it and look back and, you know, it'll be clean. But part of it is that, I say that in line, but it's, you know, it's having the discussion, because my brother, who's a medical doctor, was putting his child to sleep with milk at night, and I'm like, dude, what are you doing? He's like, I don't know, like, keeps him happy, you know, it's, you know, so. We probably don't follow it closely enough, or for long enough to give like a good answer to that, but I have not been, that hasn't been brought to my attention in a negative way, either in the research or with other specialists that I talk to in other states that do this. I probably don't have like a perfect answer for you, but it hasn't come to me negatively. But we probably don't follow it closely enough or for a long enough time period to probably be able to give you a good answer. So, yes.
Pacifiers, how do we make them?
The worst. I love them because then you're gonna see me for worth it.
Either, you know, so.
Yeah.
What do you recommend?
Cut a hole in it.
Okay.
Yeah, cut a hole in it.
Two or
Oh,
maybe
No, totally. Yeah, it's gonna make that whole palate narrow because the maxilla is two bones. And you have cartilaginous tissue in between. That's why you can expand. When they get to their teenage years, it all fills in with bone, and that's why you gotta do surgery later. But yeah, it'll super narrow and then it's V-shaped. So it's not just the teeth. You're seeing the teeth like this because the teeth sit in the bone. The bone is going like that. So by 2 years old, you want to be done with it. So after 2, it will fix itself. If you get it out of the way, it'll come back down in time. But beyond that, it'll still get better, but it's not. You start to have some defects with the actual bone that hold the teeth. Yeah. Yes.
Reasonable, do you feel like thinking about the collaborative effort and just the consultation, like how reasonable is it for like one of us to come to the consult with you just to really be part of that conversation?
I've never had it done, but I think it's more probably I think it's the way that you want to practice and what the family wants. Yeah, I mean, we've never had it done. I mean, we don't care. We're open to it. Yeah, if you want to be involved in it and kind of be there, and I think it might be a good like learning experience if you want to do it once or something like that. But yeah, we're open to it. We've never had it done. So
I mean, I'm coming from a little bit, I'm a feeding therapist, and so coming from just kids that are already having like kind of traumatic experiences with food for whatever the reason might be, and thinking about, okay, really weighing the pros and cons of doing a procedure like this, especially on an older infant, like unfortunately, I have had a few experiences, not a lot, but where it's gone really bad. So just thinking about more extreme cases, I think like that.
yeah.
It's nice to know that just, hey, let's just go part of the conversation.
Yep. No, those are ones that I appreciate because then I'm not making the decision. You know, it's like they've been working with someone like you, and then you're probably finally making a referral, like, hey, let's try this, or let's see. And it's like, okay, well, mom is engaged, she knows what's going on, we're trying this. It makes the decision for me to move forward a lot easier. So, yes.
I know we're probably done, but.
All I have is time, maybe. That's what it is, no, he's taller, darker, more handsome, all the things
So I just,
that he doesn't want to do, he doesn't, autism. Is that what you said?
no.
Okay.
Get a lot of parents who need referrals for their autistic kids or kids who need like a low sensory environment. Would your office be one of those like good referrals?
Yeah, we have quiet rooms, we have open bays. So the American Academy of Pediatric Dentistry has designated, children and adults with special needs to pediatric dentists, because they get lost. Like, general dentists don't wanna see them, family dentists don't wanna see them, they don't know what to do, a lot of the times. If they need work done, there's resources we have for sedation as they get older and stuff. I mean, we see adult special needs patients, so they have nowhere to go. So, yeah, but no, I think autistic kids who have autism are some of the coolest kids. You know, I do ortho on them really successfully. You know, you gotta take your time a little bit. They want everything explained, like what is going on, what is that, what are we doing? They want, yeah, it's like, I like it. It's kind of a nice break. Talking with them, they're very intelligent. So, yes.
So on the sedation route, we see so many kids that can't have anything coming towards their mouths. So like if you get to 2.5, 3 years old and they really need to go see somebody, can you sedate that young or do some sort of?
Yeah, 2 years old is what the anesthesia team wants.
Okay.
So to get up to that point, we really want all the teeth in the mouth, but we kind of make that decision. I mean, we have done it, we're not, and when I say all the teeth, there's those 4 last primary molars.
Okay.
That you want to get all those in so that when you go to sedation, you're really doing it one time. You know, I have it 6 months later, now there's new cavities because those teeth weren't in, so sedation again.
Okay.
But, I mean, send them to a pediatric dentist, don't let that be a barrier. But the anesthesia team wants them to be 2 years old, which is appropriate, I think, for sedation, and then we can typically treat all the teeth. Before that, we'll use what's called SDF or silodine fluoride. It's basically a liquid antibiotic that kills the cavities, but it does turn the cavity black, jet black. Unfortunately, that's just the only way. But sometimes we'll do that, and then once they get to sedation, we can fix it. We can put white crowns on the front teeth.
What do you feel like is an average age to send a kid, just generally to a dentist?
Like at first,
Yeah.
like 18 months is
Okay.
probably good, because
Cool.
they've got most of their teeth by that point, and then we can talk with mom. It's still early. It's really like almost like nutrition counseling at that point, where it's here's what you do, here's what you don't want to do. Are you brushing? Are you doing this? Are you staying away from? With one of my questions, I was like, what do they want to bed with? I just asked so I can open it. What are they gonna give me? Like,
Yeah.
because they'll tell you that. You know, so.
Yeah.
Okay. Yes.
Questions for Dr. Gottens?
Just getting into it now. I know.
We've just skirted around it a lot, and I was at a visit earlier this week where a mom told me that I guess ballpark for oral tie releases is like $1,000. You did kind of skirt around it, and I wasn't sure. Like, what are we talking?
On the
Okay.
bottom. For Medicaid, we do it for $299 each.
Okay.
So.
It's nice to just be able to give a ballpark number for a family.
We're cheap in this, and I do know people in other states, people that have like done CE with and stuff that do charge like 900,000 per one, like each one.
Yeah, she told us it was about $1,000 for the quotes.
Yeah, it's I think it's 420, might be 475, 7,500
Okay.
each one.
For you guys. Okay.
Yeah, Medicaid is $299. Yeah, so, okay.
Sorry,
I don't think I saw your email.
Thank you.
I won't read them either.
Thanks. Okay, anything else?
This was awesome.
Oh, what's it? Okay. If we do need to email me. Seriously, just email me anytime. I have a card over there. Or you know what, email Dr. Marquez too. It's thrown into this. Okay, awesome, thank you.
This is